Right, beta. So, welcome back. Now, let's take a look at the surgical wounds, basically. I hope you have had something. And now, beta, this particular chapter, generally, they may not ask a single question from this chapter, but sometimes they may ask even two questions from this chapter because this is what we saw in the last 4th of June exam. Now, this is just some points here and there which are in reference to different surgical wounds. Like first bit, if we talk about that, how we can classify the different surgeries. We can, you would be doing various operations in your life, beta, if you choose the surgical branch. And if suppose I say that you are performing different type of operations. Now, if you are performing different type of operations, when you're doing different kind of operations, beta, you would be doing operations like maybe hernia, appendix, gallbladder, piles, thyroid, breast, and so many different type of operations. Based on how much amount of infection is there in a particular area, we can classify these operations into 4 categories, beta. Very simple. If there is no infection, then it would be a clean operation. But if we suspect even small amount of infection, then we'll classify this as clean contaminated operation. If there is more amount of infection, then we classify this as contaminated operation. And if suppose we are dealing with some pus type of thing, which is full of infection, huge amount of infection, then these type of operations will be classified as dirty. Right, beta? So there are 4 categories of operations based on the amount of infection: clean, clean contaminated, contaminated, and dirty. Can you repeat this with me, beta? Clean, clean contaminated, contaminated, and dirty. Can you repeat it once again? Clean, clean contaminated, contaminated, and dirty. Now, suppose you are doing surgery for maybe hernia, thyroid, breast. Now, these would not be having anything inside which can lead to infection. So, these operations are generally classified under class 1 or clean operations. And since there is no infection, so there is no role of antibiotics in these operations. When we are doing GI surgeries, now GIT, beta, as we were talking about earlier also, what is there in your GIT? If you look from mouth, pharynx, esophagus, stomach, duodenum, jejunum, ileum, cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, anal canal, in this entire GIT, you know that your intestines, whether it is the small or the large intestine, they are having lots and lots of bacteria, beta. So whenever we are doing surgeries for GIT, there would be risk of infection. Now there are 2 types of surgeries, beta. One is a elective surgery, another is a emergency surgery. Elective surgery is a planned surgery. For example, suppose a lady comes to you with pain in the right upper abdomen, and you examine this lady and you feel, okay, there is something in the right upper abdomen. You get an ultrasound done and radiologist tells you that there are stones inside the gallbladder in this lady. Now, if this is the case, that means this gallbladder stone, we need to remove the gallbladder. So what we'll do is we'll discuss this story with the patient that, look, lady, you are having stones inside your gallbladder. and we have to take your gallbladder out. So we are doing all this planning, and then we ask the lady, okay, when do you expect that you will be free so that we can plan a date inside the operation theater? So the lady might think, and suppose she came to you on 28th of July, and she tells you that I think I'm free on 17th of December. So can you take me for a date in the operation theater on 17th of December? Then you look at your schedule and you say, oh, no, 17th of December, we cannot do that. So you ask the lady, lady, can we do it on 22nd of December? Because I am little busy, little tied up on 17th of December. So can we fix on 22nd of December? And the lady thinks about it. Yeah, doctor, I think we can do it on 22nd of December. So you decide with the lady that, yes, let's go on a date in the operation theater on 22nd of December. Today is 28th of July. You are just planning this surgery. This is nothing emergency. So when you are doing the surgery on 22nd of December, when you're trying to remove the gallbladder, you know the gallbladder is having bile. And bile would be having some E. coli type of thing inside. So if suppose by chance there is spillage of bile during the operation, there might be minimal infection which we can expect in this lady. So this comes under elective GI surgery. That means minimal infection would be there. So we call this surgery as clean contaminated. And since there is a risk of minimal infection, so let's give a prophylactic antibiotic in this patient. That is, before the operation, we give an antibiotic to prevent post-operative infections, right? Another scenario, beta, 28th of July. If the patient comes to you with periumbilical pain, severe periumbilical pain, which now has shifted from around the umbilicus to the right lower abdomen, you are suspecting appendicitis, you examine this patient and you feel that yes, this is a case of appendicitis, acute appendicitis, and this patient needs to be operated in emergency. Now this is an acute inflammation, what is going on inside. That means it's a bacterial party going on in the appendix right now. That means the contamination would be more. So if you're doing this appendix surgery on 28th of July in emergency, the amount of infection expected is more. So we classify this emergency appendicectomy as a contaminated surgery. Okay. And since the amount of infection here is more, so we need to give prophylactic as well as therapeutic antibiotics, right? Then if you're dealing with any abscess, any pus collection inside, if you're draining any abscess, then we call it as dirty surgery. Again, we need to give both prophylactic as well as therapeutic antibiotic in these cases. Herein, what should be the ideal timing for giving a prophylactic antibiotic? ऑपरेशन से पहले अपन जो एंटीबायोटिक दे रहे हैं वो कितना पहले देना चाहिए? Majority of these antibiotics are given intravenously, and what we know is when we are giving intravenous antibiotic, it takes approximately 20 to 30 minutes for this antibiotic to achieve its peak concentration. That means before the operation, we should give this antibiotic not before half an hour of the operation starting. Generally, the studies have shown, look at me carefully beta and try to understand. If any operation is being done and suppose the patient has to develop post-op infection, 98% of the time, the reason for this infection is the contamination taking place at the time when the surgeon is making the incision. When the surgeon is making the incision, it is at that point of time when the external microorganisms, they go inside and they are responsible for post-operative infections. That means if we have to reduce the antibiotic load, we should give the antibiotic. If we have to reduce the bacterial load inside, then we should give this antibiotic 20 to 30 minutes before making the surgical incision. When you'll be practicing in the hospital, beta, you might come across situations or hospitals where suppose today 5-6 operations are planned and the staff nurse send all these patients to the operation theater at 8 o'clock in the morning from the ward to the operation theater. And suppose prophylactic antibiotic is given by the sister in the ward, she might give this prophylactic antibiotic at 8 o'clock to all those 5 or 6 patients. The first operation is going to start at 9 o'clock in the morning, suppose. And if antibiotic has been given at 8 o'clock, then by 8:20 or 8:30, the antibiotic would have reached its peak concentration. So that would have been the ideal time for making the surgical incision. Or suppose at 8 o'clock, the staff nurse has given antibiotic to these many patients, 5 or 6 patients, and suppose the 5th or 6th patient, the operation has to start somewhere at around 1 o'clock in the afternoon. Then giving an antibiotic at 8 o'clock in the morning will just be a futile exercise. I repeat this in Hindi, beta. जनरली ये देखा गया कि जब भी हम कोई ऑपरेशन करते हैं और मान लीजिए उस ऑपरेशन में पेशेंट को ऑपरेशन के बाद अगर इन्फेक्शन होना है, तो उसका जो कारण है, जब सर्जन साहब इंसिजन देते हैं उस समय जो भी माइक्रो ऑर्गेनिजम्स हैं वो पेशेंट के अंदर चले जाते हैं इंसिजन साइट से, और उसकी वजह से पेशेंट को इन्फेक्शन होता है। 98% टाइम्स ऐसा देखा गया। यानी कि अगर हम एंटीबायोटिक देना चाहते हैं ऑपरेशन से पहले सिर्फ इसलिए कि पेशेंट को ऑपरेशन के बाद इन्फेक्शन ना हो, तो आईवी एंटीबायोटिक का जो पीक कंसंट्रेशन है बेटा वो 20 से 30 मिनट में आ जाता है ब्लड में। तो आइडियली हमें ये एंटीबायोटिक इंसिजन देने से 20 से 30 मिनट पहले देना चाहिए। अब कई बार जब आप अस्पताल में काम करोगे तो आप देखोगे कि मान लो सपोज 5-6 ऑपरेशन लगे हुए हैं आज, और सारे पेशेंट जो हैं वार्ड से ऑपरेशन थिएटर शिफ्ट हो रहे हैं। सुबह 8 बजे मान लो शिफ्ट कर रहे हैं, तो स्टाफ नर्स ने लेके सारे 5-6 पेशेंट को सुबह 8 बजे एंटीबायोटिक का इंजेक्शन लगा दिया और टिक कर दिया कि हाँ भाई एंटीबायोटिक दे दिया गया है। लेकिन हम जानते हैं बेटा कि अगर मान लो ऑपरेशन 9 बजे शुरू होना है तो 8 बजे एंटीबायोटिक देने का कोई फायदा नहीं। कोई पेशेंट है जिसका ऑपरेशन दोपहर को 1 बजे चालू होना है, उसको आपने सुबह 8 बजे एंटीबायोटिक लगा दिया, कोई फायदा नहीं होगा उसमें। तो इसलिए the consensus now is that we should give this antibiotic 20 to 30 minutes before making the incision, and ideal time is when the patient is taken inside the operation theater at the operation table. When the patient is at the operation table and anesthetist is about to give the anesthesia, at the time of induction of anesthesia we should give this IV antibiotic, because it will take 20 to 30 minutes time from this induction of anesthesia to the surgeon making the incision. Anesthetist will take some time, maybe around 5 to 10 minutes, because anesthetist is giving the inducing agent, then anesthetist will be giving the oxygen, then he'll be putting the endotracheal tube, then he'll be fixing the endotracheal tube, and then a screen will be laid between the anesthetist and the surgeon, and then the surgeon's assistant will come and he would be doing that cleaning part of the wound. He would be using that Savlon and rubbing all the abdomen or all the operative site with that Savlon. Then he'll make it dry, then he'll paint the povidone iodine, and then he'll be using some alcoholic preparation to make it sterile. So all this story will take approximately 20 to 30 minutes. That is why ideal time of giving prophylactic antibiotic is at the time of induction of anesthesia, or you can say 20 to 30 minutes before the surgeon makes the incision. Another question here. Whenever we are doing the operations, should we remove the hairs from the operative site or not? Yes, ideally we should remove the hairs from the operative site, especially if the patient is having hairy skin. Then if we are making the incision without removing the hairs, these hairs can go inside the wound and they can act as a foreign body inside, and they can increase the risk of post-operative infection. I repeat this in Hindi, beta. This was a question asked on 4th of June 2022. Very simple question. ऑपरेशन से पहले जिस जगह हमें चीरा लगाना है, क्या हमें उस इलाके के बाल साफ करने चाहिए या नहीं करने चाहिए? आइडियली अगर देखा जाए बेटा, तो किसी के अगर घने बाल हैं, अगर जंगल जैसे बाल वहां पे उगे हुए हैं, तो डेफिनेटली हमें बाल को हटाना पड़ेगा। कई बार ऐसा होता है कि आपने बाल नहीं हटाया और आपने इंसिजन दे दिया, तो ये बाल टूट के वुंड के अंदर चले जाते हैं, जिससे ये एक फॉरेन बॉडी का काम करते हैं और बाद में जाके पेशेंट को इन्फेक्शन हो सकते हैं। तो हमें बाल को हटाना चाहिए। नाउ टू रिमूव दीज हेयर्स, different methods have been used. Like we can remove the hairs by shaving. We can remove the hairs by using some depilatory creams. There are some depilatory creams available. We can remove the hairs by waxing. We can remove the hairs by using hair clippers. The studies analyzed that out of these different procedures, which will have minimum chances of post-operative infection. Let us discuss this in a little detail, beta. If suppose you are doing shaving, now this shaving causes aberrations which we don't realize, and these aberrations have got blood, and blood is a very good culture media for the growth of microorganisms, right? If you are doing shaving, abrasions, blood, bacteria, the chances of infection would be high. Also, beta, what should be the ideal time of doing this hair preparation? Should we remove the hair 7 days before operation, evening before operation, morning before operation, just before operation, or after the operation? So, 7 days before, there is no point, beta, because again the hairs are going to regrow. Evening before, morning before, all this stuff. Let us just try to understand what actually is happening in our government hospitals in India. In government hospitals, there is a government barber, sarkari nai hota hai ek, and his job is just to do the hair preparation for all the patients who are supposed to be operated. And what generally we have seen that this government barber, his duty is from 9 o'clock to 4 o'clock. He comes in the hospital at 2 o'clock and he takes the list of the patients whose part preparation has to be done, and then he goes in a sequence, remove the hairs maybe by shaving, and all these 10, 15, 20 patients, whatever they are, right? Now, if suppose shaving has been done, suppose at 3 o'clock in the afternoon, and the operation has to be done tomorrow morning 9 o'clock, that means the abrasions which have been caused at the operative site at 3 o'clock in the afternoon would be having blood, and bacteria will come in that blood. Bacteria will get time from 3 p.m. in the afternoon to next day 9 a.m. in the morning. So bacteria have got the whole night to enjoy and party. So the bacterial growth would be high if we are removing these hairs much before the operation time. We do not want to give any time for the bacterial growth. That is why we say that these hairs should be removed just before the operation, so that we are causing minimal damage, minimal abrasion, minimal blood, and minimal bacterial growth in that area, right? Okay. Out of shaving, depilatory creams, waxing, hair clippers, the studies analyzed that hair clippers causes minimal damage, minimal abrasions, minimal blood, minimal bacteria. So shaving is something which is not done nowadays. It is the hair clippers which should be used just before the operation to remove all these hairs from the operative site, right? Let's take a look what all is written here, beta. So this is the classification of surgical wounds, what we are seeing, beta. There are 4 categories: clean, clean contaminated, contaminated, and dirty. Clean, where there is no infection; clean contaminated, minimal infection; contaminated, significant infection; dirty, gross infection. No antibiotics for clean, prophylactic antibiotic for clean contaminated, both prophylactic and therapeutic antibiotics for contaminated, both prophylactic and therapeutic antibiotics for dirty operations. The clean operations where there is no infection, this includes thyroid, breast, hernia operations. The clean contaminated include elective GI surgery. Elective GI surgery. And contaminated include emergency GI surgery. Emergency GI surgery. While dirty include abscess drainage or any surgery done for removal of pus. Right, beta? Now, in this elective GI surgery, elective cholecystectomy. What is cholecystectomy, beta? Removal of gallbladder. Elective appendicectomy. What is appendicectomy, beta? Removal of appendix. Now, when we have to give prophylactic antibiotic, we should know that this prophylactic antibiotic should be given 20 to 30 minutes prior to making the surgical incision. 25 minutes or 20 to 30 minutes prior to making surgical incision, or on 17th of December, they can give you at the time of induction of anesthesia. At the time of induction of anesthesia, this is the ideal time for giving a prophylactic antibiotic. To remove the hairs from the operative site, skin preparation, removal of hairs, it is done by using hair clippers just before the operation. Hair clippers just before the operation. This was the question on 4th of June 2022. Since they asked this on 4th June, they may ask this on 17th of December. Right. If the examiner is talking something about emergency GI surgery, whether emergency cholecystectomy or emergency appendicectomy, then this will belong to class 3. Class 3. Right, beta? Now, suppose the examiner does not mention the word elective or emergency. Suppose the examiner simply mentions, look at me on the screen. Suppose the examiner simply mentions cholecystectomy. No elective or emergency word is used. Suppose the examiner writes appendicectomy, and he may ask you, this belongs to which category, this belongs to which category. So in general, beta, we should know that most common surgery which is done in emergency by the surgeons, general surgeons, is appendicectomy. That means appendicectomy is most of the time done in emergency. So if the examiner has not specified, you will mark the answer as contaminated, while gallbladder operation is the commonest operation done on elective basis by the general surgeons. So gallbladder removal is majority of the times done on elective basis. So this comes under elective surgery, right? Okay. And whenever we are doing any treatment for pus, whether it is a incision and drainage, this will come under class 4 category, that is dirty, right? Okay. Now, Another topic in this surgical wound, the keloid and hypertrophic scar. We know that we have got a very lovely and cute faculty of pathology with us, Dr. Kunal sir. This is his domain. With due respect and regards to Kunal sir for this particular topic, I'm just giving you a little brief about this topic, though he takes this topic in detail. Whenever we are doing any operation, the healing takes place by the formation of a scar. This scar can be a good scar, it can be a bad scar. Sometimes what happens when healing is taking place in the skin, there may be overgrowth of collagen and fibroblast. And this overgrowth of collagen and fibroblast may give an ugly scar. If suppose I say that this is the surgical wound and now healing is taking place and there is overgrowth of collagen and fibroblast in this area. Now, if the story remains confined within the limits of the original wound, we call it as hypertrophic scar. But if the story extends beyond the limits of the original wound, for example, in this particular picture, if you see, this story has extended beyond the limits of the original wound. And generally this extension, what you're seeing, this is taking place in a claw-like manner. If the overgrowth extends beyond the limits of the wound in a claw-like manner, usually we call that as keloid. The name keloid is derived from the word claw. Okay? So sometimes beta, after the operation, when you look at the scar, there may be overgrowth of collagen fibroblasts which are confined within the limits, that is hypertrophic scar. If it extends beyond the limits, that is a keloid, right? So by definition, if you take a look, overgrowth of collagen fibroblast confined within the limits of the wound. This is a hypertrophic scar. Extend beyond the limit of the wound. Extend beyond the limits of the wound. This is a keloid. Usually in a claw-like manner. Usually in a claw-like manner. That is a keloid. Another important thing, difference between hypertrophic scar and keloid beta. This hypertrophic scar, what you see, this particular hypertrophic scar can resolve spontaneously without any intervention. मतलब hypertrophic scar अपने आप ठीक हो सकते हैं. But keloid, what you're seeing here, they do not resolve spontaneously. They require some or the other intervention and then we can treat them. These keloids, they are more commonly seen in blacks, more commonly seen in females, especially the Afro-Caribbean. That means the African people, the West Indies people, the keloids are more common. They are more common over the places where God has given very less amount of soft tissue in the body. The common site for both hypertrophic scar and keloid beta is sternum. If you roll your fingers over the sternum, you will find that there is hardly any soft tissue over the sternum. So whenever there is any wound over the sternum, when healing is taking place by overgrowth of collagen and fibroblast, the body tries to overprotect this area by increasing the growth of collagen and fibroblasts. So they are more common in those areas of the body where the amount of soft tissue is less. If you look at the tip of the shoulder, you can feel that bony prominence, the tip of the nose, the ear lobule. These are the common sites for these hypertrophic scar and keloid. If we take a look Spontaneous resolution is common in hypertrophic scar. Hypertrophic scar has got no predilection for white or black or male or female, but keloid is more common in blacks, the African and the Caribbean West Indies people. Keloid are more common in females. The common site for both is sternum. Those areas in the body beta where the amount of soft tissue is less, the chances of overprotection is more. Since hypertrophic scar can resolve by itself, अगर कोई चीज़ अपने आप ठीक हो सकती है तो हमें किसी दूसरे के इंटरवेंशन की ज़रूरत नहीं पड़ती. No intervention is needed in these cases. In our Indian scenario beta, after the operation, when the scar has developed, then the doctors suggest the patients you can use some coconut oil and put that coconut oil daily on that scar. Or maybe in foreign countries you can say they would be advising some moisturizing cream. The reason for this coconut oil or moisturizing cream over the scar is just to keep the scar moist, so that if by chance you don't use this coconut oil or moisturizing cream and you allow the scar to remain dry, अगर ये सूखा रहेगा, then cracks can develop. And if cracks develop in the scar, this can easily be invaded by external microorganisms. That is why we suggest these patients to use some coconut oil or maybe massage with a moisturizing cream. So you can just write coconut oil as well here. In Indian scenario, this is what is something which is we commonly prescribe. However, keloid, which is not going to resolve spontaneously, we give steroid injections into the keloid. Generally, 3 to 6 injections are required at an interval of 21 days. हर 21 दिन पे कीलॉइड के अंदर एक स्टेरॉइड का इंजेक्शन लगाते हैं, जिससे शायद जो कोलेजन फाइब्रोब्लास्ट हैं उनकी ग्रोथ कम हो जाए. So what we can do here is intrakeloidal injection of triamcinolone. Intrakeloidal injection of triamcinolone. Generally 3 to 6 injections at an interval of 21 days. If suppose even after giving the steroids, the keloid persists, then we have to do a surgical removal. And just surgical removal alone is not sufficient, because if you just surgically remove that keloid and leave that area like that, again there will be healing by collagen fibroblast. Again the keloid will form definitely. So the chances of recurrence would be very high if you are doing a simple surgical excision. What we can do beta, after removing the keloid, we can put some radioactive material into that area. Maybe some cobalt seed, small seeds of colloid can be put into that area after surgical removal of keloid. This will keep on releasing cobalt or radiation at lower doses, and that will help in minimizing the overgrowth of collagen and fibroblast. We can call this as surgical excision and radioactive seeds in the bed, or you can say interstitial radiotherapy is what we can do in the treatment of keloid. Right. Then another small topic in these wounds is something related to ulcer. Now what is an ulcer beta? If we just try to understand, suppose this is the skin, then beneath the skin there would be, or you suppose this is the epidermis, then there would be dermis, and then we know there would be some subcutaneous fat, and then we know there would be underlying muscle, and then there would be bone, right? Now what is an ulcer actually? Ulcer is somewhat like this. Ulcer simply means breach in the continuity of epithelium. That means if you look at this particular area here, the skin is broken here, right? This breach in the continuity of epithelium or mucous membrane is called as a ulcer. On the outside, we talk about so many different ulcers like venous ulcer, Marjolin's ulcer, diabetic ulcers, rodent ulcer, and so on. tubercular ulcers, syphilitic ulcers, right? Healing ulcers. Inside the body, we talk about, say, peptic ulcers, right? So breach in the continuity of epithelium or mucous membrane is a ulcer. Now, if we take a look at this ulcer here, suppose I say that this is the ulcer which is developed somewhat like this. This yellow story, what we are seeing, suppose we say that suppose this, what we are seeing is the ulcer, right? Now, this is the breach in the continuity of epithelium. This particular border, what you are seeing, beta, this is called as the edge of the ulcer. This is the edge of the ulcer. And when you're looking from the top, this what you're seeing here, this is the floor of the ulcer. This is the floor of the ulcer. And this area where the ulcer is resting, this is called as the base of the ulcer, right? So this what you're seeing, this is the edge of the ulcer. This what you're seeing from the top is the floor of the ulcer. And the ulcer is resting at the base of the ulcer, okay? What is relevant to understand here, beta? Many times, just by looking at the edge of the ulcer, we can get an idea of what is the underlying disease, why this ulcer has formed. I repeat this in Hindi, beta. जो जख्म होता है, अल्सर होता है ना बेटा, ये जब स्किन टूट गई है या अंदर म्यूकोसा टूट गई है तो अपन उसको अल्सर बोल देते हैं. अब मान लो ये पीला पीला जो दिख रहा है ये अल्सर है, तो ये जो कॉर्नर है ना बेटा, ये अल्सर की एज होती है. अगर अपन ऊपर से इस अल्सर को देख रहे हैं तो जो नीचे का हिस्सा दिखाई दे रहा है ये फ्लोर है और ये जख्म जिस पे बैठा हुआ है वो बेस है. ऐसा कहते हैं बेटा कि ये जो अल्सर की एज है, इसको देख के हम आइडिया लगा सकते हैं कि भाई इसको डिजीज क्या है, कौन सी बीमारी है इसको. फॉर एग्जाम्पल, इफ यू सी अ स्लोपिंग टाइप ऑफ एज, देन दिस मीन्स it is a healing ulcer or an inflammatory ulcer, or it can be a venous ulcer, right? This edge, what you're seeing here, beta, this looks to be a sloping edge. This is a sloping edge, what you're seeing. This is seen in healing inflammatory or venous ulcer. Now, there might be another scenario. Suppose the ulcer is somewhat like this. It is just the opposite, beta, what we drew earlier. Now, this type of edge, what you are seeing here, this is called as a undermined edge. Undermined edge. And this is seen in a tubercular ulcer, TB, also seen in pyoderma gangrenosum at times. Another type of edge, beta, if suppose it is straight on like this, now here you can see this is a sharp punched out type of edge. You can see this is a sharp punched out type of edge. slow motion what you're seeing, beta. This can be because of two reasons, I feel. One, probably it is raining heavily outside, so maybe it is causing some fluctuation in the internet connection, or I'm using quite thick colors here, so probably the iPad is taking more time relaying this information to the software. So let us not worry about it too much. Probably because of heavy rains, this is lagging a bit.